And we'll pause. Hey everyone, thanks for joining us today for a PASSE Facebook Live. We're going to give you an update, but first we're going to go around the room and introduce ourselves. I'm Lainey with DHS Communications.
Hi, I'm Melissa Stone. I'm Division Director for Developmental Disability Services.
Hi, I'm Paula Stone. I'm the Deputy Director with Division of Medical Services, which is Arkansas Medicaid.
Hello, I'm Michelle Huey with Arkansas Total Care.
My name is Jeff Allen, and I'm with Summit Community Care.
Hi, I'm Shelley Rose, Provider Relations Manager at Empower Healthcare Solutions.
All right, so we're really thankful that we have all the passes here today to answer some of our questions that we know you have. Today we're going to focus for clients and families on how the transition plan is going to end on September 1st and what that means and some of the questions we know you have. So first I just want to say though, we want to take your questions, but please don't give us any personal information on Facebook. If you have any case specific or personal type questions, please direct message those instead. And then also, if we don't get to your questions, we promise we'll post a document later that kind of lists the question and gives an answer. So remember, PASSE stands for Provider-Led Arkansas Shared Savings Entity. We kind of use PASSE like we all know what it is now, but sometimes there are people who don't. This program was created to manage the services of Medicaid recipients with significant developmental disabilities or behavioral health needs. And we have 3 passes. You've met their representatives: Arkansas Total Care, Empower Healthcare Solutions, and Summit Community Care. And let's get started. I think that's a good start. So we talked about how the transition plan's ending September 1st. And so Paula and Melissa, can you just briefly explain what's going to happen for clients and families after September 1st?
You want to start?
I will. So we built a transition plan into the whole PASSE model to make sure that there was no disruptions in services. That was our intention, and we worked together with that. So the transition plan included that the PASSES would honor the authorizations for services. So the services that Medicaid was paying for that the clients were currently getting, that would continue to be authorized by the PASSES until September 1st, and as well as honoring the rates, the Medicaid rates, for both the providers that joined their networks and those providers that didn't join their networks. So that transition plan was honored by all 3 passes until September 1st.
And I think it's important, so it's particularly for clients that had, I think there was some confusion around, well, I was going somewhere before and now I can't. So it really was those services, like Paula saying, that we issued a prior authorization. So your provider received a document from the state of Arkansas, from Medicaid, saying you're authorized to receive this much therapy, or you're authorized to receive this much DDS waiver service. So this entire time though, you've always been able to request and receive Medicaid services just like you were before. But I think it was important during that transition of not cutting back any service or discontinuing any service that you had been receiving, and we had issued an okay for you to receive it before the PASSE model started.
Okay, so there's a couple of different types of services, right? There's ongoing services, right, that clients will have, and then there's like immediate type services.
Right.
Can we talk more about that?
So I think when we're talking about transition plan, we were talking more about those chronic type services.
Mm-hmm.
Particularly for the populations that are in the PASSE. So we know that the populations that came into the PASSE are Medicaid beneficiaries that are in the PASSE have a chronic condition or they wouldn't be in the PASSE at all. So as you stated, when we opened, they either had a behavioral health condition or a developmental disability condition. Mm-hmm. So those services that they were receiving on a regular basis, either a daily basis, a weekly basis, were those services most likely to address one of those issues.
Okay, so we talked about how the way services are authorized. We've just talked about, so how does a client know if a service has been approved? I think this is a good opportunity for the passes to weigh in.
I can speak first. This is Arkansas Total Care, and if your services are approved, your provider will receive a notice that those services are approved, and you're also able to see those on our portal, so you'll get notified that way.
What about denial?
A denial will also go a letter to the member and the provider as well as available on our portal.
Okay.
So again, Jeff with Summit Community Care, and we also send, if there's an approval, the provider is notified and the provider should be communicating with the patient with regard to that approval. If there's a denial, we send a denial notice to both the provider and the member as well.
So this is Shelley with Empower Healthcare Solutions, and we notify the provider and the member of both an approval and a denial for services.
And I think right there, I think what Paula and I really wanted to focus on this a little bit today was because of the confusion out there of the difference between how you get a service approved and what's on a person-centered service plan. And I think particularly for my DD families that have been on the waiver, they've always had a person-centered service plan, and that's what we've always called it. And this is a different process for those members and those families, how this is going to operate. So I think before, just so everybody's clear, what we did was at DD, when we approved the plan, then that was an automatic approval for every service that was on the plan. So that's how people knew whether or not their service they were requesting was approved. And this is a switch from that process. And I think if we could just take a minute for you to explain kind of what we've been talking about of just the difference now and kind of what this looks like. Because I do think it's causing confusion.
I do, and so I think that for many of the services, there was already, particularly on the behavioral health side, a prior authorization process. And that prior authorization process was a beneficiary, a Medicaid beneficiary would go to behavioral health provider. They would say, I know I need some services. I'm not sure what services I need, but I know I need some behavioral health services. And then that provider would then work with that beneficiary, assess them, and determine what types of services they need. And then that provider would then write a plan, a treatment plan, and then they would submit that to Medicaid's utilization review or utilization management group to ask for an authorization for those services. If those services got authorized, then the providers would submit that claim to Medicaid and they would get paid. And so there's all kinds of things in our system to make sure that that claim got paid if the services had an authorization. And they had a treatment plan for those authorized services, but that was developed by the provider. The treatment plan itself was not really approved. The services on that treatment plan were approved. So now for the behavioral health side, I think it's a little clearer that treatment plan is now going and being part of the person-centered service plan. So that relationship continues between the provider of service and that PASSE member, that beneficiary, Medicaid beneficiary PASSE member. But the care coordinator is capturing that and making sure that that beneficiary has all the services they need. And so they are not themselves authorizing the services, and they are not then recommending services.
Right.
But what they're doing is then saying, okay, this service is needed, and they are capturing that service is being provided
That's
on the
right.
person-centered service plan.
So I think it's important to understand. So when you enter the PASSE, through whatever door you enter the PASSE, we want your needs to be met if the service is deemed medically necessary for you, and you would benefit from this service and live a more independent life. So what Paula is saying, I think the PASSE model mimics very closely kind of how the behavioral health providers have operated. And so for the DD providers, doing treatment plans for the particular service that you're doing for the member, and then that same member, although they're maybe intellectually disabled, could also be receiving behavioral health services under the PASSE model, and many of them are. So they'll be getting treatment plans from behavioral health providers that the care coordinator kind of will compile and put into this overarching PCSP. But it doesn't have everything. So it's talking more about the difference between chronic conditions and immediate conditions, because everything cannot be captured in a PCSP.
Nor
So-
would you want things like, I go to see my physician annually for this kind of checkups. You
Right.
probably wouldn't have that, but I think more of those services provided by those providers. And then also services provided by maybe like an OTPT speech therapist.
Because those are on a regular basis.
Services may be provided by, maybe if you have a chronic condition that's being treated by a neurologist, that
Right.
you're getting those on a regular basis, so those regularly provided services.
What we don't want to see, because Paula and I have been seeing this on Facebook, and so have the passes, because we're trying to make sure we're catching kind of the concerns of families, is that I think there's a lot of confusion on what needs to be in the PCSP and what needs to be told to the care coordinator and when. And we want to emphasize today these immediate, urgent type services do not need to receive any kind of approval process from your care coordinator. So please don't feel like if you can't get a hold of your care coordinator that you can't take care of those needs for your loved one. And I think each one of y'all can talk a little bit about that, right?
Yes, so if you have emergent services, we would expect you to seek those emergency services without contacting us at all. And you could contact us afterwards and let us know and follow up with your primary care provider.
Yeah, I would agree also, if you need immediate services or even urgent services, seek that care where you need to. It is good always to follow up with the care coordinator. Most of us are tied in. If you have an emergency visit at a hospital, most of us will receive notification, but it is good to loop the care coordinator back in that care.
Right, and this is Shelley, and I agree with both Michelle and Jeff that if you have an emergency, seek that emergency help, but also if you have a cold, just go to your doctor. That doesn't have to be something that you have to contact your PCP or your care coordinator. You should contact your PCP, but your care coordinator about. Just go see your doctor and get that taken care of.
So if most clients should have a PCSP, what if there was a new service they need? Where's a good starting place for a client?
I would say to start with your provider and talk through that with them, and they would submit that for an authorization and a review for approval.
Yeah, I think for any additional service, you would always start with the provider. You can communicate with your care coordinator. The care coordinator can help you communicate that with the provider, but really the provider needs to contact us for that service, and we would approve that service if it required approval and note that where it needs to and make sure you receive that.
Right, and I would agree with that. Your care physician, whoever that is, that specialty provider or whoever, is going to let you know the services that you need, and they're going to make that appropriate referral to whatever that physician is. And so it's always going to start with them to get that request in for an authorization. And they can, once you get that review in, that authorization review, the care coordinator will be notified. If it needs to be added to the PCSP, it would be at that point.
And then just last, a question we have seen, and I think it's important to address, is what if the PASSE is not covering services that were covered before?
So the way we've written our agreement with the PASSES is that all of the Medicaid covered services have to be covered by the PASSES. So they have to be available, they have to be offered, which is different than they have to be authorized. So just as we did when everybody was in the Medicaid fee-for-service world, the services were available in our state plan, they were available through our waivers. Not everybody got every single service in the state plan. We still had a process for approving those services to be provided or to be paid.
So I think just really quick to reiterate something we already said, whose responsibility is it to get these authorizations? Not the client, right?
That's right. It is not the client's job to worry about getting the authorizations. They can seek help from their care coordinator if they need to identify a service provider. They can't find somebody. They know they need a service and there's not a provider available, or they need that set up very quickly and they need some access to services. But back to what these guys said, is it is directly that authorization is between the provider and the administrative arm of the PASSE, because
Okay.
the PASSE have an administrative arm as well as this care coordination, and they're separate. They're separate entities.
Okay. So, we've seen, just some concern about this. What should a client do if he or she got a bill from the PASSE, or really from the provider, right? That's where they're probably getting this bill. So what should they do? Let's talk about what is supposed to happen real quick. Policy of it.
So, people in the past, as everyone here knows, are still on Medicaid, right? We're still talking about Medicaid recipients. So, we don't charge Medicaid recipients for covered health care. So I think a couple of things are happening. I think when people are going to the doctor, they're signing a stack of paperwork, and in that stack they might be signing something that guarantees that they will cover the cost of a service if for some reason their insurance or their or the PASSE will not. So I think that is causing some confusion. But Medicaid has always had a rule in place that states that Medicaid will cover payment of all covered services that we provide. So I think there's a couple of things we talked about when we were getting ready for this. Now, if someone wants to go out and get an elective surgery, right? Liposuction, right? A facelift. Although I won't need one after this camera could flare, and that's why I'm coughing. It's so hot with these lights. But an elective surgery, plastic surgery that's elective. Medicaid's never covered that. The PASSEs aren't going to cover that. If y'all want to sign that you will cover something like that, of course we would expect you to pay for that. But if you're getting a service that Medicaid has covered in the past, that we have always covered, you should not be getting a bill for that. And if you are getting a bill, what we want to talk about today is what you do with that bill. Because I know that when you get a bill, it's easy for us to go, oh, well, you don't owe that, so don't worry about it. But in reality, that can cause people a lot of anxiety and grief and worry about their financial credit score. So we wanted to talk today about, with each PASSE, if you get a bill for a service that should be covered, where do you send it?
For Arkansas Total Care, if you were to receive a bill, you can contact your care coordinator, or you can contact our member services department and let them know. We will need to see a copy of that bill so that we can reach out to that provider and have a conversation with them. I would say take about 5 to 7 business days to get that resolved at the most.
Okay.
Yeah, and I think that it's pretty similar, but if you receive a bill, there's kind of two things I have seen that members have received bills for. One, we've paid, but the provider may be billing for an additional amount on top of that. That's really not allowed. That's called balance billing. But there may also be no payment yet from the plan, and so they may be billing you as the member. In either case, as everyone has indicated, if it's a covered service, the provider should not be billing you as a member. And so our first step, we always recommend you call the provider, because we have found many times with this transition, the provider may not be aware that you're with the PASSE, may have billed a different entity. So make sure that the provider has your subscriber information and that they billed the correct entity, which they may have billed one of the other PASSes. So that's kind of the first step. But if you have received the bill, as Michelle said, if you can get us a copy of the bill, you can contact your care coordinator, you can contact member services. We actually have a local care coordinator call center as well that we can provide that phone number for, and they would then coordinate with the provider relations team, my team, and we would contact the provider and try to resolve that. And we typically have resolved that in 7 to 14 days. So we've not had challenges really when we've reached out with the provider to get that resolved.
So I'm Shelley with Empower. The first and foremost, agree that the provider should not be balance billing the member. And so if you do have a provider that's handing you a bill, we ask that you give a copy of that bill to your care coordinator. You can reach out to them via phone, you can text them, you can email them, you can give it to them face to face. And the first thing that the care coordinator does is reaches out to the provider themselves just to make sure that, again, they have your subscriber information and see if they can resolve it on the front end. If they are unable to, then they escalate that to PR, and we reach out to them and just make sure that they know that there's no balance billing, that they need to bill the PASSE or Empower directly, and how they go about doing that. If they're not in network, we talk to them about getting into network, and just so all of those things. Now, I don't want to give you a timeline on how long it takes to resolve that. It could be the same day, but if it's a network issue, it could be longer than that. And so I don't want to say specifically, but I do want you to know that as a member, balance billing is not allowed. Please don't pay that bill and get it to us so that we can handle it for you.
Okay.
Yeah, can I just add one thing there also? I think we've seen many instances where, and this is a good thing, provider will send a statement to a member to let them know that they billed the insurance company. That's not necessarily a bill, so if you can make sure you read what you've received from the provider, we can still help you with it, obviously, but we have seen many times that providers just notified you, hey, we billed your insurance organization and we're waiting for that payment.
That's a good point.
And then I just wanted to add that just by some fluke, that they are not responding in the way that they just said that they're responding. I'm sure they will, just to make sure of that, but just in case something happens, you can always call the Office of the Ombudsman.
Yes.
I think that's important to
And we'll
know, that
post-
if it's not going as they're explaining, that they should call us and we would make sure we follow up on it.
Yes, and we'll post that in the comments so you know all the appropriate phone numbers for every pass and for the ombudsman office. But yes, I think that was very helpful. Thanks for that, all those answers. So then, something else we've seen, if a provider's not in the client's passes network list, right? Can the client still see them? So something changing in and out of network. So let's just talk really quick about, well, I wanna hear from each pass.
So
y'all tell us.
starting September 1st, if your provider is not in our network, they will be required to get an authorization for all services. So they'll need to contact our prior auth line to get those authorized before you get those services. With that being said, our network is fairly large and complete, so I don't think you'll see a lot of issues with Arkansas Total Care on that.
Okay.
Yeah, I think similar again, September 1st, we are requiring, that's when some of our authorizations go into place, and that includes for out-of-network providers. Summit is going through a little bit, taking a little bit different approach. We're doing a transitional authorization period. So for the things that might normally require authorization, we're giving providers an opportunity, and this would include out-of-network providers, to submit those authorizations, but we're not going to penalize them initially in terms of any denied payments through the end of the year. So in terms of impacting a provider out-of-network, they might not see that impact of being out-of-network until January 1st, but we are requiring that authorization. It gives us an opportunity, as Shelley said before, to make sure that we're shoring up the network and trying to continue to build the network. I think we've all significantly broadened our networks. Being somebody responsible for a network, I would say the network activity is never completed. We're always continuing to broaden the network. We all have an any willing provider kind of approach in the network, so as long as providers are willing to work with us, we're talking with those providers about getting them on the network.
Okay.
So we are extending our out-of-network until 12/31, which means that effective 1/1 is when our out-of-network providers will start to see that 90% of Medicaid fees, and where they'll have to start requesting prior authorization. So for now, as we've extended that, all providers, whether they're in-network or out-of-network with Empower, will be treated as in-network. Now, if we're talking specifically about authorizations, September 1, our in-network and out-of-network providers will need to request prior authorizations on those services that require those true prior authorizations. So things like inpatient, surgeries, personal care, things like that. But that's for both in and out of network providers. And the same would also be true for extension of benefits. So if you feel like it's a service that had a benefit package, and you've exhausted that between 3/1 and 9/1, then you would need to be requesting now those extension of benefits for those services.
So can I ask a
Just-
clarifying question on that? Who's
Sure.
supposed to ask for the extension of benefits, the provider or the client?
The provider requests
like an
any
authorization.
authorization, whether that be a true prior authorization or an extension of benefit. That's never the member's responsibility.
And you feel like your network providers have been adequately trained to know what they're supposed to be requesting PAs for and extension of benefits for, right? Because that's what y'all been
Right.
focused on the last couple of months.
Right.
That is true. Empower has our prior authorization list on our website now, where they can go find what requires a true prior authorization. And within the next couple of weeks, we'll have the benefit limits published as well.
Yeah, I think we all have our prior authorization requirements posted on our websites at this point under the provider section of our websites. We're all hosting webinars and different educational opportunities for providers to educate them, not only what those authorizations are, but how to submit those, what
Yep.
documentation we may need, what the turnaround times on those are, etc. So,
And just really quick, want to point out, again, it is not the client's responsibility to be doing all the authorizations, right? I think we've
Right.
said that plenty, but we just want everyone to know that. And then also, I wanted to quickly give you their websites, because that's where a lot of this member information is, right? So Arkansas Total Cares is arkansastotalcare.com. Get Empower Health, that's Empowers, getempowerhealth.com. And then Summits is summitcommunitycare.com. So if you want to find out more about their network list, who's in network, that would be where you would do that. So then we've talked about how services are authorized. We've tried to talk about that and what providers are supposed to be doing in that realm. But then what about care coordinators? Let's talk more about that. We know there's some questions. So what is a care coordinator supposed to be doing?
I think, one, they're supposed to be adjusting their approach to the beneficiary. It's very individualized to their member. So some members need a lot of care coordination. They need a lot of assistance with identifying service providers. And I think that people that are experiencing transitions, I think about children in psychiatric residential treatment facilities. They are not going to be there long term. They're going to transition back to the community. And so a lot of intensity around that time. So the care coordinator be working with the family to prepare for that child to come back in the community, getting all those services set up. So you can see that there would be fluctuations during the year on care coordination where you may need some during transition, or there may be some times of stability where your services are set, they're going, and there's no adjustments needed. So at the very limit to this, the very base of it, they need to be contacting at least once a month. Every quarter, one of those needs to be face-to-face. And they need to be making sure that the needs are met. There should be work on if there's crisis planning that needs to be done. For crisis situations, they should be developing a crisis plan as part of that person-centered service plan, and they should be then meeting with service providers and collecting all of those treatment plans like we've talked about and putting them into the person-centered service plan, and then meeting with anybody else who's involved with. So if there is maybe a DCFS caseworker, if there's any involvement with the justice system, so there may be meetings with probation officers. So some of those that can provide those additional supports that they may be needing.
Yeah, I mean, I think that just kind of goes back to trying to clearly define the roles between care coordination and service approval, right? I think that's something that we've all struggled with under, with the transition and under just kind of a new system and how the new system looks. So just remembering specifically for the DD families, it looks very different in terms of your care coordinator can't approve a service for you. Whereas I think people were used to calling their waiver specialist, their case manager, and then it was sent to my office, and then I had a staff member approving those things, right? So this is different. It's of course you can talk to your care coordinator about anything, but the driver behind an approval or denial of a service is really through the provider community. In terms of they've been the ones trained, they have the resources in terms of being able to look on the websites and know what was required of them, and then knowing where to send that to your department, utilization management teams, and getting that approved. And then the notification, and if you guys and families being able to go on to their portals and see what's been approved and denied. And it's different, and just we're going to keep talking about it, I think, over the next couple of months, because we just want to make sure everybody understands. So we don't want people to feel like they're being held back from pursuing a service, chronic or immediate, if they can't get a hold of their care coordinator for a couple of days, right? I mean, I hate seeing that on Facebook, because I don't want anybody to feel hostage to someone answering a cell phone. So, I mean, that's awful. So we want y'all to get the care you need, and to go to the provider and ask for more service, and go to the doctor when you have the flu. And I think we're also going to talk about if you can't get a hold of your care coordinator.
Let's just do that.
And you really need to talk to somebody at your PASSE, like what do you do?
Yeah, so you might have your care coordinator's cell phone, but where else would you call?
Yeah, and I just wanted to add to the tail end of your comment about the authorizations. I think we mentioned, but we do have requirements for turnaround time on those authorizations. It's not like those are just out there forever. They're very tight timelines. We're held accountable to turn those around. So that's important to note as well. But sorry, what was the question again? Back to the care.
Where should you call? If you have your care coordinator's cell phone, you may be texting them. Each one makes themselves available to you different ways. But if you couldn't get a hold of them, where would you call?
So for Arkansas Total Care, you would call our main line, which I think you'll have to post in the comments. You can talk to our member services team. They can get a message to your care coordinator. They're there 8 to 5. If it's after hours, it's the same phone number. There's a nurse advice line, 24 hours. They also can get in touch with the on-call care coordinator if needed. So we've got you covered all the way around to be able to capture those.
Right, and our member services line, which should be on the ID card, can be posted as well. We also have and that's available 24/7. We also have a nurse advice line as part of that, so you can opt into the nurse advice line when you call that number. During the day, you can also, I think it's option 4, if you call that number, you can get our local care coordination team. So if you're unable to reach your care coordinator on her cell phone or his cell phone, then you can try that route as well.
Oh, you're gonna make me lie. I don't know what options, but you can call our member services line 24 hours a day. Again, like everybody else, 8 to 5, it's gonna come to our local office here. But after hours, you'll be able to reach just the member services, and they can direct you to the care coordinator. If it's after hours, it's going to be one of our care coordination supervisors that you'll reach. Or you can send an email if it's not like something that you need an immediate response to. Maybe you just have a question that can wait a little bit. You can send it to our care coordination email. That's monitored by all of our care coordination supervisors, and they can, if it's just, hey, I need to find my care coordinator, can you get in contact with them? You can email them. They'll get that message to your care coordinator, who can then reach out to you. And I think that Marcy's going to post those in the comments.
So,
and actually, while we're on this subject, because I think this kind of is a question that is part of that confusion that's still out there. So this is a question obviously from a provider of service, and my guess would be it's a provider of DD waiver services. So why have we received only a small percentage of person-centered service plans for our clients? And so, the expectation is that they're going to send in a treatment plan, but then they're going to get back the whole plan from the care coordinator. So
Right, and I think each pass is weighing that balance between, one of the reasons we designed the model was to have care coordination so everybody was on the same page, right? So we need all providers, BH and DD, to understand kind of who's doing what for the member in terms of the overall wraparound services for them. We're also weighing, though, that there's some things that can't be shared, right? Like specifically any kind of substance abuse treatment can't be shared with anyone. So I think this is also the difference of you're doing a treatment plan for the one particular service, and you need to know the other services the member has, but I don't think you don't have to have the overarching person-centered service plan in your hands to provide the treatment that you've been authorized to provide that member. And in many cases, it's because legally, because of protected health information, sometimes they just can't. So is that fair to say?
okay. So care coordinators help form the person-centered service plan. I think we've said that. What should a client do if he or she doesn't have a person-centered service plan yet?
Okay. For Arkansas Total Care, if you do not have a person-centered service plan yet, we need you to contact us immediately so we can get those scheduled. We've been reaching out, and sometimes we don't have the best contact information. So if you've not heard from us, if you will reach out to us, we'll work on getting that scheduled for you ASAP.
Yeah, and I would echo that exact comment. We have had some challenges reaching some folks, so if you haven't seen that and received that, you need to contact us your care coordinator, as quickly as possible.
Right, and that same is true for Empower as well. If you don't have your PCSP meeting scheduled yet, just reach out to us. You can call the member services line, or you can email the care coordination email and get that scheduled. If it is scheduled, that's already in process, and we're working on it with you.
And I just want to also note, because I know that some people, I think if I were listening to it, I might be kind of surprised when I hear care coordinators are having a difficult time reaching people. And so I just wanted to kind of give some context for that. We still have about 1,000 new behavioral health beneficiaries coming in any given month. So it is something that they're constantly looking towards. When the new behavioral health beneficiary comes in, the contact information that DHS or DMS has on file is the contact information attached to their eligibility determination, which may be up to a year old. If it came through Social Security, it may be even older than that. And so they are getting some contact information. One of the things that I know that we've struggled with all along that we know that the passes are helping with is that we have adults that are coming in through hospital settings. So that's the first time we're able to be able to intervene, get them independently assessed, and get them into a pass. But in the meantime, they get discharged from the hospital. So sometimes it's hard. So they are working to track people down that may have fallen through the cracks before. So just want to provide a little context, because if everyone thinks, how did they not have the information, or how are they having difficulty tracking the client down? That's some of the reasons. I don't know if there are others, but I just wanted to take a little opportunity to talk a little bit about that.
Yeah, it's a good idea to let your pass know if you've changed your email address or your phone number or anything like that. You often forget, who should you let know that your phone number changed? Let your pass know.
Or even if you haven't changed, if you have not just confirmed that we have the right information, that's always a good idea to do that. So,
What
yeah.
we're talking about. So I think one of the questions that came in, Lenny, is on point to what we're talking about.
Okay.
With the person-centered service plan and making sure everyone has one, and doing that sit down and going through those services. So this question is, what level of justification is required for revisions for existing plans?
And that would be existing treatment plans, not person-centered service
So
plans.
I don't know what context this is, but let's talk about it in terms of existing treatment plans. So individualized plans for each service you're receiving. And I think this probably goes back to what we talked about earlier, of that's really the provider's responsibility to be justifying, through the methods that you've trained on, an increase or a new service for that member, correct?
Correct. I mean, we provide documentation for providers, as everyone does in that education. You know, it may be progress notes or other things that we're requesting as part of that authorization request. And so they give us that, and we make a medical necessity determination. Our utilization management teams do.
But just to clarify, I mean, can you read that question one more time,
I can.
please?
What level of justification is required for revisions for existing plans?
Okay, so to me, as an LPC, that means that I've got somebody that's come into my office and they want to update their treatment plan or whatever. They have to follow whatever the guidelines are from their company, right, that their company has set up, that JCO or CARF or whatever their accrediting board has to set up. The justification for their authorization is going to be that treatment plan that they submit to us as the PASS. But they have to follow whatever their overall,
internal
yes,
that
rules
provider.
for that particular document. I think
That's
that's
good to know.
different from the PASS.
So back to the client would need to go to their provider. I mean, that's all they need to do, and then the provider is all the other things we've talked about.
Right,
Exactly.
because the provider has guidelines on how frequently those have to be updated or reviewed, and the guidelines by their overarching agency about what that looks like and how they have to document to that.
So we've talked about in and out of network a little bit. One of the things care coordinators do is help you find a provider. So if your provider chose not to be a member of the PASS, what would that person need to do? Call their care coordinator?
For Arkansas Total Care, they can contact their care coordinator, and we can help them on the portal or look at, the website, and find a provider and all the options, and we can help outreach to them to see if they're taking members and get them appointments set up.
Right, and I think we've been trying to identify those providers all along with claims data that's coming in while we've been in this transition period. So we know which members are with providers right now and receiving care that aren't in our network, so we've been trying to reach out to those providers. I think we'll continue to do that. I know Summit will, and the others before the authorizations, are hard-coded in our systems. So I think that'd be fine, just to reach out.
Yeah.
Contact us and let us know.
So for Empower, I think it's important to understand that, like you said earlier, Jeff, the network is always being built upon. There's providers that initially said they didn't want to be in any PASS that are later coming back and saying they do. And for Empower, if your provider is not in the PASS, and you feel like you need to change providers, first and foremost, let your care coordinator know, and they're going to help you explore choices from our in-network providers that are available to you. And the most important thing for you as the member to understand is that you have choice. You can choose from any of our providers that are in our network. And if you choose to go to a provider that is outside of our network, That's okay too. That's not gonna affect your ability to get an authorization with Empower. That relationship is gonna be between you, the member, and the out-of-network provider. If they choose to allow you to come to them and choose to bill Empower and choose to accept that out-of-network rate that goes into effect on 1/1, then Empower is gonna honor that. So the big thing here is for you to know that you have choice of your provider. Always go to your care coordinator and they'll help you with your choices and help you make that decision based on what your needs are, what the services that your provider or the providers that you're interested in are providing, so that you can make a logical, well-reasoned choice. But the big thing is, it is your choice.
Okay.
I just want to add one comment there. So all of our websites have a search tool for the provider directory, and that's what you're referring to. You can go to the member site, find a provider. You can often search by distance, by geography, where you're located, by city. You can search by provider type. In addition, we're all required to publish a print directory, but the print directory is outdated as soon as we publish it, so we always recommend that you go to the online directory and search as well, but that tool is out there for you.
And we may want to also, back to that out-of-network piece, we may want to talk just a short minute about the consent decree.
Yep.
Oops, I'm sorry.
Yeah, so I think just to kind of clarify, I think what Summit and Empower are saying here is that they're going to treat in-network and out-of-network providers the same for a couple more months, right? I don't want to oversimplify it for you, but that's kind of what we're saying, right? So until January 1. And ATC feels that their network is there, they're working with people, but they're gonna go ahead and start treating their in-networks providers as in-network providers, right? And work out payment agreements to pay a little bit less to out-of-network.
Right.
But by no means, doesn't mean you can't see an out-of-network provider.
It will require an authorization starting 9/1.
Okay.
So they'll have to call us and get an approval.
Right. So I think it's clear that you guys will start paying a little bit less, more than likely to out-of-network, and you probably will too in January, right? But it's important to remember with the consent decree, and we've talked about this, I think, on Facebook before, but for physicians, everyone has to be paid the Medicaid rate, right? The existing Medicaid rate, exactly what we're paying now. So there is no less than Medicaid rate for physicians, and that has been memorialized in a legal document. So that they have on file. So no, I'm kidding. So they're all going to get paid at least the Medicaid rate. So if that rumor's going around, just so you guys know that they're not being paid less than what our rate is right now.
But I think also the important thing to clarify there is that, it's an agreement between you and your provider, and if your provider chooses not to bill one of the passes, they have that right. They can say, no, we're not going to take whatever pass information, and we're not going to bill them. And so that is a choice that they make, not that we as the pass make.
But your care coordinators will help those individuals
Absolutely.
pick a new
Sure, absolutely.
Absolutely, they
Yes.
will. If that's the case, then the care coordinator is going to help you find a provider that meets all of your needs.
And you want to talk about for-cause right here? Because that kind of fits in right here when we're talking about doctors. For-cause exception.
Oh, yeah. So we have done this, we started this back in probably April, I believe we did. And so what we had was individuals that were calling, they were very concerned because their doctor did not join the network of the pass that they were in. And their doctor may have even said, we really only want to see those that are part of this one pass. And so what we've allowed to happen is if those individuals, if those pass members call our Office of the Ombudsman, then we allow them to change to the pass in which their doctor is in network. And that has been a fairly small number, surprisingly small number, but we call those changes for cause. We allow people to change for cause to another pass. Another reason we've allowed people to change for cause is because there were siblings in a home that were all in a pass, and they got assigned to 2 or sometimes 3 different passes. And so we allowed parents to call us and to say, we're going to choose one pass on all of our children. So we've allowed that for both physicians and for siblings.
That's right.
So I think we've covered a lot of what care coordinators do. Care coordinators receive ongoing training from the PASSEs that they are employed by, but they also receive some outside training from different companies like AFMC and also Mid-South, and we'll post some of those in the comments so you can actually see the training they're getting. I want to add to that.
I would just say that we're constantly training our care coordinators, as with any role within our company, constantly training to keep them up to date with changes going on.
I would agree with that. Constant.
If you go to that Mid-South link, you can watch a riveting video Paula and I did. I'm fine. No, but it actually is a good training. I think we did care coordinator training. There was about 400 care coordinators.
More than that.
Maybe 500 viewing, where we talk about tiers and independent assessments and global payments and person-centered service plans. So I think it's helpful.
And the
if you wanna-
services that are available, that was one of the things
That's
that
right.
we really talked about, is because people were confused and said, oh, I got a behavioral health independent assessment.
So I can't get any of that, which is not
That's
true.
right. Mhm.
Right? So we talked about all that. We talked for, I don't know, about like 2 hours.
I think that's a good transition into independent assessments, just a couple questions that we know people have. So everyone who is in a PASS already got one independent assessment, right? But at this point, it would be a reassessment, another assessment, an updated one, right? So do clients have to get an independent reassessment?
So there's a requirement for both populations. So if your initial assessment was behavioral health, and you are not on the DD waiver or waiver wait list or in an ICF, then you would need to get an annual behavioral health reassessment. So it is not annual from the date the assessment was done. We have put them into groups, and so to make that easier, so we've extended the dates for those to make sure that people have that chance for reassessment. For the DD members, those are every 3 years.
Okay. And then we heard a question from a client that said that their child previously was a tier 3 and then they were reassessed at a tier 2, and they wanted to know, would that change their coverage?
So no, it shouldn't. And I think if you go to the Mid-South link that we talked about a minute ago, we talk about that at length on the care coordinator training. So the tier for PASS members, it looks at your functional assessment, it looks at your functional ability the day that the assessment's done, and it tiers you, right? And that drives a payment to the PASS for their network of members. And so once you get into the PASS, it's a risk-based model, right? That's the beauty of it, where money can be shifted around depending on the member's needs. So there's not a dollar amount tied to Paula or me, right? So the whole model is based on shifting when we need to shift. So what drives your service is what we've been talking about this whole time, which is what the provider is requesting and what's approved through the UM, and what you're kind of talking to your care coordinator about, and what ultimately gets approved for your service package. And that is a shift, especially for DD clients. It is a big shift. If you have more questions on that, you can reach out to one of us, and we're happy to send you the PowerPoint of that presentation we did if you can't find it.
We'll post it.
But we are getting a lot of calls, both from the behavioral health side and the IDD side, saying I went down, or something's happened, and I need more service, and so therefore I need Optum to come out and reassess. And that's not really the goal of the reassessment, is not to try to put you from a 2 to a 3 or a 3 to a 2, because the service package is really driven by what we've talked about today.
So can I just add to that too?
Yes.
So the authorizations, when we require an authorization, is based upon medical necessity, and medical necessity, it has nothing to do with the tier assessment.
That's
So
right.
regardless of whether you're tier 2 or tier 3, your medical necessity for the service is based upon the service and your condition.
That's right.
And what is appropriate for you to help improve.
Right, so the functional assessment or the independent assessment that you get from Optum really just puts you into the PASS.
Right.
If you're a 2 or a 3, you get into the PASS. And then once you're in the PASS, like you said, Jeff, those services are based on medical necessity. So if you need them and your doctor justifies them on your authorization request, then they get approved, regardless if you're a tier 2 or a tier 3.
Okay, so Paula talked about for cause a minute ago, but in October, open enrollment is gonna happen, and everyone will have the opportunity to switch if they want to. But they don't have to, right? So tell us more about that, Paula.
Open enrollment will be October 1st to October 31st, and anybody can call the PASSE beneficiary support line, and they can make a decision to switch to a new PASSE. That will be recorded, and the switch won't actually take place until December 1st, but they would be able to make that decision. So we've been getting, again, calls asking to switch passes, not a lot, but some calls to switch passes, and there wasn't a for-cause reason. Maybe there was something about they lived in a group home, and they saw the care coordinator that was coming in for the other people in that group home, and they liked the care coordinator, and they thought it'd be much easier if they all had the same care coordinator in that group home. So that, we didn't consider that a for cause, but those people will be able to call in October to make that change. And that change, again, will, we want some time for the passes to understand who they're getting, get that information, so it's not an immediate change. For causes is more immediate. And this will then take that time where the passes will get their list of new clients and then be prepared to start leading those services or paying for those services on December the 1st.
I think I'll just add, we are spending time with each pass, trying to finalize kind of how this is gonna look, right? In terms of if you wanna switch passes, how is the new pass going to see what treatment plans have been approved, what your PCSP looks like, and how everybody's up to speed. That window, since it's not starting, it won't take effect until December 1st. It will give us some more time, but we're actively working to finalize, and we'll be pushing out a lot of information. Like beneficiaries will get a letter about open enrollment. I'm sure Lainey and Amy and Marcy and team will be putting out a lot of stuff on social media, so there'll be a lot more coming on this, probably in September, which is what, like in a week. You know, but we'll be putting a lot more out about this, and I don't want people to feel like you have to call us to let us know you're happy and that you don't want to switch. But you just need to sit tight, right? And that we will not switch you unless you call us and we verify that we're actually switching you. So.
Okay. Do we have any more questions that have come in that we want to cover today? We tried to cover the big things we already knew about, but.
Somebody asked a question, how do you know what pass your provider is in? So I would pitch it to these guys.
Your child. Did I
How do you know?
You sure a provider?
How do you know
It's
what
child.
pass your child is in, not provider is in?
They need to call the ombudsman's office, and we can
We'll
post
post
that
it.
number.
We're gonna post all the important numbers.
And
But
go
I can-
ahead and answer the other one.
Okay,
just
yeah.
in case.
So how would you know which pass your provider is in if they're not in all passes?
So you can ask your provider if they're participating, or you can go out to our website and look on our Find a Provider tool and find your provider there.
Yeah, the provider should be aware if they're participating. Since we've all been broadening our network, some providers may still be in the process, so they may let you know that, but it's certainly available at their office or on our online tool.
Right, the Empower Find a Provider is on the top. There's a navigation bar on the top of our screen, and you can always click on that, type in your provider's name, and you should be able to see. Now again, I would reiterate that the network is being updated every day by providers, and so if you don't see them today, they might be there tomorrow, as it takes a minute to load into the system.
Any more?
Yeah, I mean, these two probably,
I think so.
right? You wanna talk about this one? Cause we've been talking about that. We talked about this yesterday with our reporter, a little bit about how we feel like the first 6 months of the PASS launch have been really focused on making sure no one loses their service, making sure providers understand how to bill, getting the networks up to speed, stabilizing, right? And this next wave that we've been working on is cooler, more fun stuff like outside the box service, right?
That's right.
Because that's the whole purpose of the model, is to not be tied to these very strict and boxy Medicaid regulations, and to be able to offer a better service array to PASS members. And we have it available, but we'll start pushing out kind of this new message of what that's going to look like. And since that talks about a benefit package, it's kind of what we've been talking about, of, you know, getting together and trying to figure out how's the best way for this to work, and is there a better way for us to be doing this?
Yeah, so this question is, tell us if there will be a benefit package in the future, and if so, when. So and it's really kind of depends on which provider type this came from. So I know for behavioral health providers, there have been traditionally a benefit package of a certain array of services that either didn't require a prior authorization and were just a package of benefits, and then once they hit the limits of that benefit package, then they would ask for additional, or there would be a prior authorization for a full package of benefits, and they could have up to a certain amount of each of those services within that. So this is a question on the benefits package, and I think, you know, as Melissa just said, we're really looking towards having some more innovative services.
Right.
And so,
Flexibility.
and some more flexibility with that. And so I think, you know, while the passes, and I'll let them answer, doing some planning on benefit packages, we're really also looking at thinking about this in a very different way. And so I think one of the things we were looking at is the difference between a home and community-based services. Home and community-based services that might not be medical in nature, and then services provided by professionals like
Clinicians, doctors,
yes,
nurses.
therapy
Right.
services, counseling services, those kinds of services, and that those would always, that may likely be prior authorized or continue to be prior authorized, and that those are different types of services, and so there might be different packages of services. So the passes are looking towards, you know, are they gonna authorize those services together if they are provided in a combined way? Or are they gonna look at it in a very separate manner and say, these are home and community-based services, and there would be a package of those services, and the medical services, the services that require a medical necessity determination would be either part of that package or a different package. So I think that we don't want to recreate it just like we recreated it on the Medicaid fee-for-service side, so for those benefit packages. So I don't know if you guys have additional information about benefit packages or how that would be interpreted.
I know Arkansas Total Care is, we have a benefit package for behavioral health that is available on our website. We've been going over our webinars. That's a package of services that you would receive before you need to get an authorization. So we're training on that now, so more to come on that.
Yeah, I mean, we actually aren't taking that approach from the fee-for-service Medicaid. So, you know, we've listed the services that require prior auth. Many of our behavioral services don't require prior auth, but some of them do. But we're not authorizing in terms of packages per se.
So Empower has benefit limits again for the behavioral health. We have some for many of the different provider types out there, but I think the message that I think that you as the member needs to hear is that all that you need to worry about as a member and all that you are responsible for is going to your treating provider, talking to them about what you need, and it is their responsibility to know what that benefit package is, and it's their responsibility to request that authorization or that extension of benefit for you. Your job is to go seek treatment and follow the directions of whatever that treating provider tells you to do so that you get better. But it's the provider's responsibility to do everything else and worry about benefit packages.
And then I think the last question here, that my favorite topic. So offering services to people on the DHS wait list. So we have about 2,400 people in the PASSE right now, children and adults, that have been waiting a very long time. Well, all of our clients on the wait list have been waiting a very long time for the CES waiver services. So we were able to put 2,400 of those people into the PASSE already because they were getting Medicaid state plan services, and so they were given a care coordinator, and the care coordinator should be working with you guys to, if they haven't already, to gather treatment plans if applicable, and developing you a person-centered service plan. Even if it's just to coordinate your state plan services at this point and make sure you're getting everything that you need. But we're really excited about the passes having to pay the insurance department a premium tax, because that has given us a new revenue source that we did not have here at DHS or at DDS to give funds for people on the waiting list. And so, yes, we fully anticipate being able to make an announcement very soon of being able to offer more service for people in the PASSE on the DDS waiver wait list to help you while you wait. It does not take you off the waiting list. You're still on there for a fully funded slot, which we plan to add to those in January, February of 2020. Also a premium tax. So this does not negate that. This is really a package of services that will be available to you that have not been before because of the generosity of the premium tax. Is there anything you'd like to add to that? Thank you. So we're excited, and we're planning on doing some more on that as well in the next couple of weeks.
All right, I think that's about all we've got time for. We want to respect your time, those of you who've joined us. We will post in the comments all these important numbers that we've been referencing. We'll make sure you have those. Thank you so much for joining us today. Thank you all for being here to answer questions. We have tried to give you all a good update about what's going to happen after September 1st. We've tried to make sure you have all the things you need to know and what you're supposed to be doing as a client or a family member of a PASSE member. If you don't have a Facebook account, we actually are going to be posting this on YouTube. So you'll have more than one way to watch this again. If you missed anything,
Yes.
if you missed anything during this video, please rewatch it, please share it, and we'll make sure that anybody who's not on Facebook also has an option to watch it. As always, you can find out more information on the PASSE program at pass.arkansas.gov. Thanks for joining us.
Thanks.